in Melbourne, Victoria. In the past I've worked with youth and adults in detox. I've worked outreach with intravenous drug use, using people. I was counselling service manager and I used to write programs and run 2 drug and alcohol rehabs. And I was taught AOD to Swinburne University undergraduate psychology students, as well as teaching undergraduate and postgraduate students at the Australian College of Applied Psychology. So, sorry, I'm not great with technical stuff. I don't know what I've done here. Anyway, while that's happening, I just want to say that when I make reference to clients today, it's all been de-identified, and I've changed and amalgamated a few cases. Okay, so there you go, I should get my certificate in IT. Okay, so let's go. This presentation is about the male cohort with ASISA, and it is usual for an ASIA client to present to the therapist often with a binge drinking or alcohol use issue, so it's not really disclosed in a lot of cases straight away. And of course the partner, if there's partners involved, the partner is usually aware of the alcohol issues because that's really obvious, and some might be suspicious or even involved in some of the stimulant uses. And when I talk about stimulants today, we're talking about cocaine and methamphetamine. But the partner's often totally unaware of the sex addiction. ASISA clients cross over no socio-economic or ethnic boundaries and affects the gay and the heterosexual males. And I've seen clients from the age of 18 to 82 years old. And there was a study in 2006, and there's not much on it in this field, but Fong identified men with sexual addiction that they've been diagnosed with a lot of comorbid disorders, and Fong found that 96% of them had an anxiety disorder, 71% had a mood disorder such as depression, 71% had a substance abuse disorder, 46% had a personality disorder, 38% had an impulse control disorder, 83% of self-identifying people with sex addiction all agreed that they were dependent on alcohol and drugs. They identified themselves as workaholics and compulsive gamblers. And 14% had obsessive compulsive disorder. And a lot of these are very congruent to the presentations in my own practice. So let's have a go at this. So let's identify, identifying in ASISA is pretty much counselling 101, Rogerian type counselling, because you've got to build rapport. So we all should know that building rapport encompasses normalising. Okay, so with normalising, we start off with our client with alcohol. And you'd never, ever ask your client what they drink or the quantity, because most of them will tend to feel real shame and they're going to minimise. So if you want to really get an accurate picture, you might say something like this. Hey, some of my clients might drink 2 bottles of wine or drink a slab a day, or some of them, when they're having a binge, can go over 15 standard drinks, and I'm wondering how that is for you. And of course, we need to probe further because we're looking for ASISA. So then I might, from there, say something. It's quite common for people to score ice or coke when they've reached what I call the alcohol or drinking stuffer button. That's when they lose most of their control. And I'm wondering if you sometimes score. This is a hard part, okay? And a lot of therapists have got to learn this, that you've got to get out of your comfort zone. because some therapists just won't scratch where it doesn't itch. But if you're working with ASISA clients, only, you must scratch. You need to ask the question and you need to explore. And you need to ask them, and you need to say, hey, you're going out, you're clubbing, you're drinking, you're doing lines of coke, or maybe you're doing ice. So it's really common for a lot of people to watch hours of pornography after that. Visit happy ending massage shops, going to strip clubs, brothels, getting on online chat forums, exchanging images, etc. So you've got to ask your client if this resonates with them. And naturally, it would be expected that you explore any drug-induced psychosis, because many of my clients report paranoia at the time of using and coming down, and this is often a really good motivator to stop. So those that are familiar with the cycle of change or stages of change will identify this as the contemplation stage. A typical example is some clients have reported to go to a club venue or hotel. They drink alcohol and they reach that stuff at button. They score cocaine or they score ice. A lot of them book into a room in a hotel. They go on a bender and they watch hours of pornography, or they go on chat lines, or even call in some escorts. And believe it or not, this can go on for 2 days. And some, again, what I talked about, feel so paranoid that they can't even leave the room until they straighten up. So, people ask me, what comes first, the chicken or the egg? And this is a very complex question, and it's really hard to get this right. So we have to just consider the following things. We have to ask, does our client have a history of sexual or pornography addiction? And when sober, does your client experience any underlying sexual anxiety, including but not limited to erectile dysfunction, premature ejaculation, as well as any of the underlying disorders as identified in Fong's study? Also, you've got to consider, is your client experiencing cognitive dissonance? Are they actually grappling with their sexual identity? And are they using alcohol and stimulants to be able to fulfill their true desires? You've also got to establish now whether it's just when your client binge drinks and go past that stuff it button again, that the client may act impulsively, doing lines of stimulant, feeling sexually aroused, then acting out sexually. I just failed the